Hello and welcome to the webinar, In a Nutshell, Biomarkers and Cervical Cancer. I am cervical cancer treatment. I'm Aisha McClellan, the cervical cancer coordinator at SHARE. Before the program begins, I'd like to tell you a little bit about SHARE. We are a national nonprofit that supports, educates, and empowers anyone who's been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms. For more information about upcoming webinars, support groups, and our helpline, please visit our website at sharecancersupport.org. Now I'd like to hand it over to Dr. Salani to introduce herself.
Hi, everyone. My name is Ritu Salani. I'm a GYN oncologist at UCLA, where I'm division director, and I'm really passionate about cervical cancer, and I lead the NCI task force on cervical cancer, and I'm involved with the NRG, which is our research trial cooperative group in cervix. And I am so thrilled to be here, and I just want to thank SHARE for having me and putting on a great resource for patients and caregivers.
Thank you. Okay, so we have a few questions. So how can understanding the specific genetic or molecular features of my cervical cancer help doctors tailor my treatment plan to be more effective? And what kinds of treatments might be recommended based on these features?
Yeah, so cervical cancer is unfortunately one of these cancers where we have an opportunity for primary prevention with the HPV vaccine because that's kind of its root cause. And I think it's important that we talk about vaccination and also screening, which can detect cervical cancer, cervical dysplasia in earlier stages. Now, unfortunately, many patients may not have access to this, or even despite access, may still develop cervical cancer. And there's a couple of things that are really important to understand about how cervical cancer is treated and how factors may inform that treatment. So first, it's going to be stage. And so imaging is going to be a really important part. Imaging and examination are going to be a really important part of assessing kind of the disease stage. And I'm going to speak a little bit off turn here, but just, a lot of people are just like, oh, just cut it out or just do surgery. And unfortunately, that's not always the case for cervical cancer, where surgery may actually be more harmful. So understanding the exact stage of your disease and imaging examination will help with that. But then also kind of understanding what that treatment means and why that treatment is important. You want to do things that are going to enhance your outcome or give you the best outcome without causing harm or even delaying treatment. When it comes to genetics or molecular features, there's a couple of things that would be important. One is the HPV status. Not all, but most cervical cancers are HPV positive, and there are different strains of HPV. Now, this may just be kind of more informative at this time, but there are targets being developed, particularly for HPV 16, which is the most common type of HPV infection that occurs with cervical cancer. And so knowing what your tumor kind of pathogenesis or causes can be informative. There are other molecular characteristics in cervical cancer, but we haven't quite figured out what to do with them just yet. And probably the one that's most important, we'll talk a little bit more about it kind of as we get in more advanced stages, is PD-L1 status, or what we translate to what's called a combined positive score, or CPS. And this can help inform the role of immunotherapy in advanced settings. In locally advanced settings, like patients who may need chemo and radiation, immunotherapy may still play a role, but the marker may not be as important because most patients actually carry it, or their tumor carries it, I should say.
Right. What are some of the latest tests or biomarkers that doctors use to predict how well cervical cancer treatment might work for me? And how do these tests help improve my treatment outcomes and quality of life?
Well, we always want to find the treatment that's going to kind of enhance the best outcome without causing toxicities. And this is still a challenge. So I mentioned PD-L1 status. This is an immune marker, and it kind of lets us know if immunotherapy will be effective. Most patients' tumors do carry this PD-L1 expression, and so immunotherapy can really play a key role. Now, that being said, there are other biomarkers or markers that we may see. I mentioned HPV 16 as a potential target. There are a lot of other biomarkers that are continuing to be explored. And so the really key thing about that is you may be a candidate for a clinical trial based on your biomarker and may have access to a treatment that may be the future of cervical cancer care, but it's still being understood or explored further to determine if that's the case. This may include things like TROP2, TROP2, which is kind of something that we're studying now. We think that based on preliminary studies, it looks like most patients also have this expression, but the rate of expression may be important. So if you're a high expressor versus a medium versus a low. And same thing with PD-L1 status. We're kind of seeing that same high-low expression kind of being teased out a little further. There are other markers like tissue factor, which also, unfortunately, most cervical cancer tumors express this, and it makes it really ripe for multiple targets that are being approved nowadays. There are some other interesting targets that I think we just don't understand if they're really driver mutations. What I mean by that is just because a tumor has those mutations, it doesn't mean it's important. It just may be like a you know freeloader mutation is just hanging around, and this might include things like PIK3, PIK3. BRCA, as a matter of fact, which is commonly seen in ovarian cancer or breast cancers. We see these mutations, but we just don't know if they're important or not. And so understanding this, participating in clinical trials or, doing lab work and understanding the true kind of driver sense of these is going to be important.
What are some ways to detect cervical cancer early?
So this is so important. One, getting the HPV vaccine, and we recommend this really kind of in the preteen ages, so 11 and 12 being the most prime time, but it's the HPV vaccine is FDA approved up to 9 to 45 years. So that's probably the most important way, but getting pap testing, HPV testing is really important. And there's data that shows that even one pap HPV test in your lifetime can actually reduce the risk of cervical cancer development. It's not a perfect test though, and we know that there may be errors in interpretation or kind of, false negatives, if you will, where the test is done, it doesn't show anything, but just didn't detect it. Now, HPV testing can enhance that, where the virus is shedding, and that can be detected even kind of with a little bit more accuracy than the cell itself. But that's really the key. And so it's really important, whether you've had the vaccine or not, whether you think you're high risk or not, to get that kind of routine testing and assessment. Data has shown that we don't have to do it every year. When I was first starting out, we used to do this every year, and we were probably, creating a lot of anxiety, unnecessary testing, and unfortunately, unnecessary interventions because of what we thought were abnormal results, which were really kind of self-contained. But now we are doing it kind of, if you have normal results every 3 to 5 years. And I think this is kind of minimizing some of that anxiety and cost associated with it. But you have to remember, and when you're not doing something yearly, even yearly, it's hard to remember, but when you're doing something once every 5 years, it can kind of slip off your radar. So make sure you ask about it every time. If you're getting your mammograms, your colonoscopies, and other testing, just ask your doctor, hey, am I due for my pap test? And they might tell you no, you have another couple of years. But missing that is a really lost opportunity for me, especially, it doesn't matter which doctor it is. It doesn't have to be your gynecologist. It could be any doctor who can tell you if you're up to date on your pap testing or not.
Yes, very, very good point. Are there specific biomarkers that are being researched which might provide new options for treatment in the future? And how might these discoveries impact my current or future treatment plan?
So this is a really exciting area. Cervical cancer research was kind of at like a low level over the last 15 years, but then all of a sudden there's been an explosion and a really great interest in it. And there's a couple of reasons why. One, the TCGA, which is kind of like the genome analysis, where they do kind of a gene assessment of cervical cancers to look for mutations, came out just about 10 years ago. Not quite, but close to. And so this has really kind of helped shape our understanding of how we can better treat cervical cancer. And one of the things that came out of that is the immune therapy, which has really revolutionized the management of cervical cancer. And so what they found is that there's some amplifications of immune targets in most cervical cancers. And this made, and we know it's caused by an infectious agent. So targeting the immune system actually really is logical in this setting. And so, studies were done, and we actually improved patients who have frontline metastatic disease, so cancer that's spread from the cervix to other areas. Adding immunotherapy actually improves survival, progression-free survival, meaning how long you live without the disease, and how long you live overall. And this is really a huge advance because we really hadn't seen this in quite some time. The other really cool thing was it didn't harm patients' quality of life. As a matter of fact, patients had maintained an excellent quality of life despite getting another therapy. Then what we did is we looked at immunotherapy added to chemoradiation. So kind of in that even earlier frontline setting. And we found that that also made an impact in how long patients will live without the disease recurring. And these are really two big advances, but they're not enough because until we say we've cured it, we have to keep working. And so now looking at other combinations of options of therapies, whether it's immunotherapy combinations. We have a new drug called tisotumab vedotin, which has new FDA approval. It's also known as Tivdak, and that's used in second line, but there are some provocative studies of combining that with immunotherapy. And then, HER2 expression is also something that's been studied. I've mentioned the PD-L1 and HPV, but there's a lot of patients who have HER2 expression that can be even independent of HPV positivity or cause. And HER2 is really, we don't know the exact rate. It's not the most common finding in cervix cancer when I'm talking about is HER2 expression. So this is tested on your tumor, but there is a target for it. And in a study, we saw really provocative and exciting results using a HER2 antibody drug conjugate in cervical cancer, which was actually kind of better than what we've seen across the board. So if you are one of those patients who has that mutation, expression, it's something to really talk to your doctor about. So, PD-L1 expression, looking at immunotherapy, HER2 expression, looking at maybe trastuzumab deruxtecan. I mentioned earlier TROP2, and this is a study that we're actually just opening up now. So if you have recurrent cervical cancer and you're looking for trial opportunities, this is something that would be a very interesting option. Most patients have it, but the rate of expression may be important. So kind of looking at low, medium, and high, and understanding how patients respond to this. I mentioned tissue factor or tisotumab vedotin is another area. We don't test for tissue factor because it's almost 100% expressed, but it's also a very interesting option. And then new studies looking at things like Nectin-4, which is a common target in bladder cancer, is also being explored. And this is just the tip of the iceberg. There are lots of other avenues that are kind of being researched, maybe not ready for prime time or even the bedside or clinical trials just yet, but continue to be explored in the lab or the bench setting to look at more opportunities for our patients. Oh, there's one other thing I want to mention. Sorry, Asia.
No, you're fine.
The other thing is the HPV-16 target. So HPV-16 is a common cause. HPV is a common cause, and 16 being one of the more common viruses. And looking at vaccine options to target patients with cervical cancer. This has been really exciting and preliminary, and so it's being further developed. Kind of finding the right target group, whether it's in the recurrent setting or even earlier, is really, really cutting edge. So I think it's also another exciting area.
No, this is super exciting. How often should I expect to have biomarker tests done during my treatment, and how will the results of these tests influence the decisions of my healthcare team will make about my care?
So these are all fantastic questions. And I think one of the most important things before I answer the question is actually talk to your doctor about what the testing they've done on your tumor and understand it. So, they might say, oh, you have a squamous cell carcinoma or you have an adenocarcinoma. That's a type of cancer, but ask, is it HPV positive? And if it is, they may be able to tell you what type. It's not always tested. And what other testing have you done on my tumor? What's my PD-L1 expression or my CPS? Ask this and understand what that may mean. Am I a candidate for immunotherapy? Why or why not? And then, thinking about biomarker testing, it's not done routinely. And so biomarker testing, we typically are doing on the tumor. So unless there's a change in the tumor or you're having a repeat biopsy, the role of repeat biomarker testing is not really clear just yet. Now, as we get more information, there may be new tests that we want to test. So it may not be repeat testing, but adding new testing onto it. So for instance, if you had cervical cancer 5 years ago, they may not have done PD-L1 testing. And so this might be something if your cancer comes back, hey, what tumor testing can we do? So know your tumor testing and write it down because you won't remember. And actually, write down notes on what that actually may represent. Now, there are some other biomarkers that are being explored. And one of the really interesting things is ctDNA or ctHPV DNA. CT is circulating tumor. And so what this is a blood test to see if you have tumor circulating in your bloodstream. And that might actually tell us if your treatment was effective, we would expect a clearance, or if we see signs of recurrence. Now, this is still being explored. We don't quite understand what the role is in today's treatment landscape, but it's being studied. And how great would it be is if you could have a blood test to see if your cancer has responded or if your cancer may be at risk for or higher risk for coming back. And that might inform how closely we monitor you, or if we initiate if and when we initiate treatment for recurrent disease. And so it's still pretty early, but I think it's a really exciting avenue for patients to have another way to kind of monitor their cancer. Not ready yet, but I think
I know I'm ready to get the
tumor-
test today.
I know circulating tumor DNA, I think is going to really help inform monitoring patients.
That sounds amazing. I love it. It sounds like there's been so many advancements. It's really exciting.
It really is.
So what are some of the main takeaways about this that you'd like patients to know?
So I think, we've had this like really great explosion of new data in cervical cancer. And this is a testament to patients enrolling in clinical trials, which has really helped advance the field, which is pretty, stagnant for about 20 years. And now all of a sudden we've had this great explosion and it continues in a good way. Not every new drug is going to be positive, but I think it's worth exploring. And we need to learn how to move the treatment landscape forward in a way that improves outcomes, isn't financially debilitating, and isn't toxic, meaning it doesn't impact quality of life. Because as you know, many of these patients are very young, and so we want to make sure that we are able to not only improve quantity of life, but really enhance quality of life. And then I think the other thing to think about is, if you're watching this, you may actually know or have cervical cancer, and we need to reach the patients or the people who don't. And so talk to your friends and family about getting screening for cervical cancer, getting your, kids, grandkids, yourselves vaccinated if you qualify. I think really primary prevention, preventing the disease, or secondary prevention, which is catching the disease before it becomes cancer, is so much better than treatment. And anytime we do that, that is a win. So, I always joke like the best thing I could do is put myself out of business, and I would be totally fine with that because that means we've cured these cancers. And we have a long way to go, but starting with kind of grassroots, people listening, share it with friends, colleagues. And, oftentimes people think cervical cancer is kind of a shameful disease because, of the HPV exposure, and it's not. 80% of people are expected to have HPV in their lifetime, and the less we talk about it, the more it's going to linger. And so I think it's important we are vocal about it. We are, just raising awareness like this program is, and advocating for ourselves, clinical trials, research, understanding biomarkers. All of these things are the right things to do.
Wonderful. Oh my gosh, thank you so much. You've jam-packed so much in 15 minutes. We really appreciate it. I've learned a lot. I have a whole page of notes here. Thank you so much. We really appreciate you. Please make sure to check out Share's upcoming educational programs and support groups and follow us on social media. This concludes the program today. Thank you, Dr.
Thanks for having me.
Salani, and thank you all.
Bye.
Bye.